Hello, I'm Dr. Licollari. Today we are conducting an in-depth clinical comparison between Buruli ulcer and squamous cell carcinoma, two distinct conditions that often present as chronic skin lesions. While their origins differ fundamentally, one being infectious and the other neoplastic, they share clinical similarities that can complicate diagnosis, especially in endemic regions. Buruli ulcer is a necrotizing disease caused by Mycobacterium ulcerans. The hallmark of the infection is the production of mycolactone, a potent lipid toxin. Crucially, mycolactone is both cytotoxic and analgesic. This means it destroys tissue while simultaneously numbing the area, leading to remarkably painless massive tissue destruction. The infection typically begins as a firm, non-tender nodule, a painless area of induration or diffuse swelling of a limb, which can often be mistaken for an insect bite. As necrosis progresses, the skin breaks down into an ulcer. A classic Buruli ulcer features widely undermined edges, where destruction extends centimeters under apparently intact surrounding skin. Modern management focuses on a specialized 8-week course of antibiotics, typically a combination of rifampicin with clarithromycin or moxifloxacin. During treatment, lesions may appear to worsen. This is often a paradoxical reaction as the bacteria die and the immune response heightens, sometimes requiring steroids. Shifting to squamous cell carcinoma, this is a malignant tumor arising from keratinocytes, primarily driven by chronic exposure to ultraviolet radiation. The primary driver is DNA mutation, specifically within the p53 tumor suppressor gene, often exacerbated by chronic inflammation or long-standing wounds. SCC typically presents as an enlarging, firm, erythematous nodule or plaque. It frequently develops a central ulcer with a crusty or keratinous surface. Unlike the painless nature of a Buruli ulcer, squamous cell carcinoma is often tender or painful to the touch, a critical clinical distinction for practitioners. Visually, SCC borders are typically everted or rolled rather than undermined. It's also the second most common form of skin cancer globally. While Buruli ulcer stays localized, SCC carries a 5% risk of metastasizing to regional lymph nodes or distant organs, requiring careful monitoring. Management is primarily surgical. The goal is complete removal with clear margins, typically 3 to 10 millimeters of healthy tissue around the tumor. For high-risk sites like the face or hands, Mohs micrographic surgery is the gold standard, offering real-time microscopic examination to preserve healthy tissue. To summarize, BU is bacterial, painless, and undermined. SCC is UV-induced, tender, and everted. One requires antibiotics, the other surgical excision. Distribution also varies. BU is most common on lower limbs in temperate areas, while SCC favors sun-exposed sites like the scalp, face, and ears. A critical intersection exists. BU scars are prone to carcinomatous degeneration. SCC can develop within a chronic Buruli ulcer scar years after the initial infection. If an ulcer fails to heal after 8 weeks of antibiotic therapy, or if a healed scar begins to bulge or bleed, a biopsy is mandatory to rule out SCC. Recent cases have even documented the simultaneous occurrence of both conditions in a single lesion, where malignancy provides a portal of entry for bacteria. Ultimately, histopathology remains the definitive step to establish the diagnosis and guide the appropriate management plan for the patient. Maintaining a high index of suspicion and ensuring early assessment is key to preventing the severe morbidity associated with both of these conditions. Thank you for joining me for this clinical comparison. For more information on skin health and dermatological care, stay tuned for our next case study.